Good morning, good afternoon, good evening, wherever you are. Welcome to the IMS Women's Health Partnership Symposia Series. A warm welcome to all attendees from across the globe. This free initiative is designed to expand healthcare professionals' access to world-class education on menopause and midlife women's health, featuring insights from leading global experts. The IMS, in collaboration with its partner societies, present online symposia covering cutting-edge topics in women's health and menopause. These sessions are globally accessible, ensuring
Andersen.
healthcare professionals worldwide can benefit from latest research and clinical advancements. Happy World Menopause Day, a day initiated by the International Menopause Society, celebrated on October 18th every year. This year's theme, lifestyle medicine, and one of the 6 pillars we are promoting is restorative sleep, a very befitting topic for today's symposia. Today's symposium, what is sleep, what is menopause, and how do they interact, marks the 4th event in the series, presented in partnership with World Sleep Society. This webinar has been supported by an unrestricted educational grant from Bayer. Bayer has no role in the selection of topics or speakers and has not vetted or reviewed the content of the speakers' presentations. I am Dr. Pramita Damodaran from Malaysia. I serve on the board of International Menopause Society. I have championed menopausal health for over 30 years in Malaysia and am presently the president of the College of Obstetricians and Gynecologists and chair the local menopause and midlife committee. It is with great pleasure I would like to introduce my World Sleep Society co-moderator, Professor Dalva Poyares. She is a Brazilian medical doctor, professor, and researcher specializing in sleep medicine and neuroscience. A highly accomplished academic and clinician, she has held positions at the Federal University of Sao Paulo and the Instituto do Sono. Professor Dalva Poyares.
Hello, thank you for the kind introduction. I apologize, I have a voice problem right now, but we are very honored to have to be invited for this meeting. And we have the 3 esteemed speakers with us today. Should I introduce them? So the first one is Professor Monica Andersen. She is Associate Professor at Department of Psychobiology at Federal University of São Paulo, Brazil. She is a director of Sleep Institute and editor-in-chief of Sleep Medicine Reviews. And she will be speaking on sleep. What is it? What it is? Why we need it? And how we measure it. And she will be followed by the esteemed Dr. Fiona C. Baker. She is a world-leading expert on women's health and sleep. She is also a director of the Center for Health Science and Human Sleep Research Program at the SRI International, and which is a non-profit research organization in Menlo Park, California, USA. She also holds an appointment as honorary professional research fellow in the School of Physiology at the University of Witwatersrand, Johannesburg, South Africa. She will be speaking on sleeping in women across lifespan. And the third one, Professor Pauline Maki. She's a professor of psychiatry, psychology, and obstetrics and gynecology at the University of Illinois, Chicago, and a leading researcher on menopause and women's cognitive and mental health. For over 25 years, her NIH-funded work has examined how hormonal changes and menopause symptoms influence cognition, brain function, and mood, as well as the effects of hormone therapy. She is a past president of the Menopause Society, and currently she serves as treasurer of the International Menopause Society. Her research has been recognized nationally by scientific organizations, advocacy groups, and US government offices. She will be speaking on the impact of menopause on sleep, why it matters, and how it happens. And then it's my pleasure to announce the three esteemed speakers in order.
So thank you very much for these very kind words, Dr. Poyaris, and thank you all for this very honored invitation. So I'm going to share my slides to not be late here in this very important event that we have here. Just let me know, let me see. Are you seeing the whole screen here?
Yes.
Yeah, okay. So again,
Professor Andersen, just a small announcement. The presentations will be followed by a short discussion and Q&A. Please do submit any questions you have. If you were unable to address them today, we will collate all questions and provide written response afterwards. And please do take your time to fill our symposium survey. Thank you.
Okay, thank you very much. Again, it's my great honor to be here. And according to this title, I planned to make a presentation with many questions. So it's not just why we sleep, but how much do we really need and how to measure it. So why, how, when, how much, and the consequences, especially for us women. So congratulations for this very nice presentation today, that we have so many esteemed speakers, especially because I have been following Dr. Fiona for so many years. I have students that she has like an idol in the person of Dr. Fiona. So again, it's great to start this presentation with all this questions that we have. How much sleep medicine really costs to our society, and how we can prevent all the negative and outcomes that we have for some sleep disorders. So starting with the first one, how much I really need of sleep, and do I need to sleep that much? So we have different functions, as you very well know. So if we are not sleeping well, our cognitive processes are going away. And for the last 5 years, we have talking a lot about the immune system as the interface with sleep. A very good psychiatrist knows that it's very important to have this overlap between sleep disorders and mental conditions, and cardiology and sleep, and metabolic syndrome. So we have so many functions that we really have to learn more about the effect of sleep. But if I have to point one, I would say is the balance, is the homeostasis, that sleep is the main factor for this equilibrium that we have. Now I go to a second question. How to measure sleep? So since the 60s, and especially from Chicago studies, we know that we have different time of sleep for each one, and the sleep pattern can be measured by the polysomnography. So when I'm teaching to the students, I always mention that we are able to record different parameters that make the hypnogram that is very distinct to everyone. So as you can see, we have a major sleep pattern here that you can see like a sleep latency according to like 15-20 minutes. Then we have the REM sleep. Then we have the non-REM sleep that we can classify in N1, N2, and 3. For the first 4 hours, we have the essential sleep. And after that, we have the following hours where the sleep, that is the moment that we have the rapid eye movements, is more concentrated. And for this entire night, we are going to have the quantity and the quality that can be measured. If I know how to measure it, now I can ask the next question. When do we sleep? And how is the sleep according to different people here in the world? So as we all know, we have a Gaussian curve in which we have few people that is short sleepers and a lot of people that is in this average of between 6.5 and 8 hours per night. And then we have few people again, around 2% that needs to sleep more than 10 hours, that we will call them the long sleepers. And again, when we talk about when the sleep happens, we also have to include the chronotype. So the morning type, the evening type, and most of the people are indifferent. We can adapt a little bit more easily to the event that happens nowadays. The society works in a way that most people have this average between 6 and 9 hours of sleep, but it's important that each one consider their own chronotype to exert their activities that we have. How much sleep do we need? Since Hof worked in the 60s, we know that when we are born, we have 16, 18 hours, almost 20 hours in 24. And this sleep time reduced to the elderly. So I'm 52 now, so the menopause is just knocking on my door. I have around 20% of REM sleep. So the sleep that most reduce across life is the REM sleep. And if we talk about animals, and so many studies have been happening in the literature about sleep time in the phylogeny of sleep, we can see, for example, rats, that is major than in the sleep studies. When we talk about experimental studies, they sleep around 12, 13 hours a day. Can we stop sleeping? That is another question that usually the young one ask, because they want to produce more, so they want to improve of their time that they're spending awake. But actually it's not the case, because we know that sleep deprivation take our productivity, take our creativity and our imagination away. So when we sleep deprived, we will have the consequences. So here I'm going to list some of them: shorter life expectancy in animals, chronic hypertension, injuries, accidents, and higher mortality of cardiovascular diseases, just to mention some. But if I'm going to talk about, in particular, women, see, we have poor sleep in many cases, and then we have several demands on this person that have to take care of their own personal life, the familial life, the professional life, and still be able to coordinate that. So more and more we are seeing studies reporting higher prevalence of sleep complaints in women. So if I have to list some of them, for instance, socioeconomic pressures, society standards and pressure, double or triple shift, and stress. In fact, here in Brazil, we have additional one. This is the long commute between work and family's house. If we are going to point specifically in women, we have sleep disorders considered in different studies of having higher prevalence of insomnia. So in that study here, we can see almost 50% of women complaining about insomnia. And in our study here in the Sleep Institute, we found that 26% of women have sleep apnea as well. So the main complaint for this sample is fragmented sleep, circadian rhythm changes, and we have to also consider different comorbidities as hormonal situations, mood disorders, and also pain states. How to prevent? So sleep hygiene is considered a very important tool to improve quality of sleep. And as we all well very know, we have to prevent thinking about problems. Is very easy to say, but difficult to incorporate. How a woman with so many triple shift and so many social economic pressure should be able to avoid not thinking about problems. But if everyone could include some sleep hygiene method before going to bed, we will improve the quality of sleep and also the amount of sleep. We have to respect the chronotype, limit the alcohol intake, reduce heavy food consumption just before going to bed, and of course exposure to cell phones and all kind of electronic device 2 hours before going to bed. If I have to consider one of them as the main one, I would say we have to establish more regular schedules. Waking in the same time, going to bed at the same time, but also our meals have to have a schedule during the day. And sleep in women is a very complex topic, but also very provocative. As we are taking more responsibilities, we are now seeing women in CEO positions and having very high demands. But as a maternal conditions, they're still facing reproductive cycles, alteration across life. And of course, menopause is one of the key points that we have to have more studies about. Lifestyle factors that have been changing, and especially with more pressure on the women. And since we are gaining more weight and we have another conditions that is now more common in the current society, we also have to consider sleep apnea and other comorbidities for these women. And we can never forget that cultural factors is very divergent between countries. So what is in Latin America is different from North America, that is different from Europe, and then from Asia, and then for all regions. So we also have to consider when we publish about women inserting key aspects about cultural and also social factors. And I would like to thank you all for your for this invitation, sorry. And here is my baby. I was mother when I was 48 years old, so very late in life. And I would like to say that late maternal pregnancy should also be considered in studies, as women are postponing their maternity condition to more late in life. And I was in menopause when I decided to have a baby. So I think that maybe sharing this picture with you also open new possibilities to investigate women that are in menopause, but also planning to have babies, that we are seeing more and more. And thank you very much for your attention. And I'm glad to share any possible questions that you have. Here is my personal email. So don't be worried to send me any kind of questions that you have. Thank you very much.
Thank you, Professor Monica. We go on to Dr. Fiona Baker.
Hello, everybody. I'm going to get my slides ready. All right. Well, that was a really wonderful introduction to sleep and why it is so important by Dr. Andersen. And I'm going to continue our discussion looking at sleep in women across the lifespan. Now, when we think about sleep across the lifespan, there are so many factors that go into what can be influencing sleep, and some of it is the aging effects. Sometimes we have to take a step back and also look at, well, what are the differences in sleep overall between men and women? And there are a number of differences when you compare sleep between men and women, where, for example, women report a greater need for sleep. They tend to have more time in bed and a longer sleep duration. But on the other hand, they're also more likely to report poorer sleep quality. And when we look and see the reasons for the poorer sleep quality, there's even sex differences in how men and women interpret sleep quality. So men are more likely to consider things like sleep duration, and how much time they're awake or how much time they're asleep as being important for their sleep quality, whereas women attribute more of the dysfunction during the day and disruption to the sleep as being important factors for their sleep quality. There's also differences in morning types, with women being more likely to be morning types. And you saw from Dr. Andersen that slide about the chronotype. So women are more likely to be morning types, meaning that they're also more likely to wake up earlier in the morning, have a sort of a shifted circadian phase to the earlier time point. And then when we measure sleep with polysomnography and look at the stages of sleep, like the deep sleep, which is the slow wave sleep, then women tend to have more of the slow wave sleep, and they tend to have less of the measured wakefulness, even though from self-reports they report that their sleep quality tends to be poorer. So there is some reasons for that. One being that men tend to overestimate their sleep, whereas women's wakefulness and what is being measured by in the polysomnography is more matched. And as you can see on the right at these figures, even when we look across aging, there are some differences between men and women, where, for example, this is the deep slow wave sleep, and women preserve their slow wave sleep more across the aging period than do men. There's also differences between the sexes in the prevalence of the sleep disorders. As shown in this figure, obstructive sleep apnea is more common in men than in women. That's the sleep disordered breathing. But post-menopause, the risk for sleep disordered breathing increases in women due to the shifts and changes that happen with the changes in hormones, also the changes in body composition. Women, when they are post-menopause, become at increased risk. On the other hand, the insomnia disorder as well as restless leg syndrome are more common in women. And you can see here on this bottom figure, when we look at the prevalence of insomnia complaints, right from starting post-puberty all the way through older life, women are more likely to suffer from insomnia symptoms as well as insomnia disorder compared to men. And there's different time points, such as in the 40s and 50s, which is the time of menopause. That's one factor that contributes to this increased insomnia that we see in women compared to men. So that's why it's important when looking at sleep in women, we don't only have to consider the sort of the age, the chronological age, we also have to consider their reproductive cycle and factors that can be influencing their sleep that are different influences compared to men's. And shown in this figure are the estrogens. That is one of our main reproductive hormones that cycle across life in women. And starting again from the time of puberty all the way through the reproductive years, you get this cycling in the estrogens and other reproductive hormones as part of the menstrual cycle. You will also get changes in the hormones if a woman is pregnant during these time points. And then as she approaches perimenopause, so menopause, the end of menses, then you get this decline in the estrogens. So it's sort of a change in the hormone environment. So across this reproductive hormone changes and across the lifespan of reproductive changes, you can see how sleep is influenced. So let's dig into that a little bit more, because it's important to remember that the history of a woman's reproductive sleep in the reproductive years can also be influencing their sleep when they're going through menopause. So when we look at the menstrual cycle, it is a very robust biological rhythm and a marker of a woman's health. The menstrual cycle typically lasts around 28 days, but there's a lot of variability between women, where for some women it may be shorter, it may be around 23 days. For some other women, it may be longer, around 35 days. Now, across this menstrual cycle, you get the hormone changes shown here, where you've got the blue showing the estradiol, which is an estrogen, which increases before ovulation, which happens in the middle of the cycle, where you see the surge in luteinizing hormone, which is what women will often use. They can measure that luteinizing hormone in urine as a marker of ovulation. In the post-ovulatory luteal phase, you get this increase in progesterone along with the continued presence of the estrogens. And this persists for around about 14 days. But if there isn't any implantation of an embryo, then those hormones decline and you start the next cycle. The sort of physiology of the reproductive system is beautifully orchestrated and controlled, and we see that it goes along with other changes in the body, such as body temperature, which is shown here. You get this very nice, predictable increase in body temperature after ovulation, and then temperature drops again if there isn't a pregnancy. Along with the temperature sensitivity, there is just about every system in the body is sensitive to these hormone changes around the menstrual cycle, which is why the menstrual cycle is so important in the reproductive years of women, where those hormone changes that happen, that cycle through, influence sleep and circadian rhythms. They also influence the immune system, cardiovascular function, and of course they change in the approach to menopause and aging. And in turn, these other bodily systems can influence the menstrual cycle. So in the case of shift work, for example, where women may be having shifted work schedules, that is associated with changes to their menstrual cycles, such as more irregularity. Not only that, there's also, when we look at the menstrual cycle, there are quite a number of women who may be suffering from menstrual-associated problems and disorders, with one of the most common being dysmenorrhea or painful menstruation. That can be very disruptive for a few days of the month when they are experiencing painful menses, and that can disturb sleep. There's also premenstrual syndrome and the more severe premenstrual dysphoric disorder, which refers to physical and emotional and other behavioral changes that are evident just before and around menses. And then there's another disorder, polycystic ovary syndrome, which is associated with hormone imbalance and irregular menstrual cycles. And that one is associated with sleep disturbances, including an increased risk for obstructive sleep apnea. So now let's look a little bit more at sleep and how is it changed or influenced by the menstrual cycle. And we can see that about 1/4 to 1/3 of women do report that their sleep is disturbed before and or during menses. If they have symptoms like cramping, headaches, bloating, breast tenderness, they will often report that their sleep quality is poorer and also that they are more tired during the day. I really like this analysis, which was done by Dr. Van Rijn and Kiesner, where they showed that they clustered their sample into 3 groups, because they showed that not everybody behaves the same way in terms of how their sleep is influenced by the menstrual cycle. And this fits very well with what we see, where we have about 46% of the sample were non-cyclic. So their sleep did not really change across the menstrual cycle. They didn't have more insomnia symptoms at any one point of the menstrual cycle. There was another group of about 25% who they noticed an increase in some insomnia symptoms around the time of ovulation. And then there was a third group, which we hear most about, which is the perimenstrual group, where they reported more sleep disturbances and trouble sleeping around menses, so leading up to and around the time of menstruation. And the factors that contributed to these cyclical changes in their sleep were related to the other symptoms, so like psychological symptoms, some anxiety, depression, as well as some of the physical symptoms like headaches and cramps. We've recently done a study where we took advantage of those wearables out there, which has really sort of exploded across the world in how people are measuring their own sleep at home. They put on a wearable, which could either be, for example, on the wrist, or it can be on the finger in the form of a ring, and it can be used as a continuous way for tracking sleep. So we wanted to use, in this case, we used the Aura ring. So it's on the finger. And we had a group of women who were in the reproductive stage. So they were in their 20s and 30s. And then we had 25 late reproductive and early menopause stage women. So they were in their 40s. And we were tracking sleep with this Aura ring across the entire menstrual cycle, so every night. And this work was led by my postdoc, Dr. Gomber Labadens. And first, what we saw was that the Aura ring was very sensitive to physiological changes across the menstrual cycle, where it picked up an increase in skin temperature in this post-ovulatory phase, which is these yellows and the brown dots. It also found picked up an increase in heart rate in those same phases and a reduction in heart rate variability, which is what we can also measure if we were to record women in with gold standard measures. It also was very sensitive to measuring the sleep changes or the sleep in women. But overall, in this very healthy group of women who did not have any menstrual-associated complaints, we could see that sleep is very well maintained across the different phases of the menstrual cycle, whether it's from menses to ovulation to mid-luteal and late luteal phase, so post-ovulation. Sleep efficiency, how well they slept, and how long they took to fall asleep were all relatively similar. And I think this is good to know, so that in women who do not have menstrual-associated complaints, sleep is so important that it is kept preserved despite the hormonal changes and temperature changes that are happening as a consequence of the menstrual cycle. That said, there is a lot of inter-individual variability with, again, some women having changes in their sleep and others not. When we look at our laboratory polysomnographic measures of sleep across the menstrual cycle, presenting the results from Dr. Driver from one of the first studies to be able to look at polysomnographic, these deep measures of sleep across the menstrual cycle. And she had the women come into the lab every second night, so very intense. And in these women without menstrual-associated complaints, they found, again, no changes in the wakefulness or in the efficiency of the sleep or in the deep slow-wave sleep. But there was some sensitivity of sleep in that there was a small increase in stage 2 sleep and a small decrease in the REM sleep in the post-ovulatory luteal phase compared to the around menses. And this finding has been replicated where REM sleep is a little bit lower in the luteal phase post-ovulation compared to mid-follicular. So it's really the REM sleep that is most sensitive to the hormone changes. And that is, if we look at the cycles of sleep across the night, the decrease in REM sleep is due to a shortening of those REM episodes across the night. Now, the factor that is the most sensitive to the normal menstrual cycle hormone changes is a measure that you can only pick up if you measure EEG, so electrical brain activity, because there are these very fast frequency events called sleep spindles that are part of our normal sleep. They're thought to be important, serve a function for consolidating sleep and also for memory function. Here is a picture of them shown here. These little bursts of activity that is an integral part of sleep. And these are sensitive to the menstrual cycle hormone changes, where what we can see is that there is an increase in both the number of sleep spindles, as well as there's a lengthening in the duration of those sleep spindles in the post-ovulatory luteal phase. So if we measure it a different way, this is activity in the sleep spindle range, we can see that there's an increase in spindle activity in the luteal phase post-ovulation compared to the follicular phase, so around the time of menses. So this is a sensitive marker of hormonal effects because we think that it is due to the higher progesterone levels and the actions of progesterone metabolites on the brain. So let's turn to look at some of those menstrual-associated disorders in sleep, which are more likely to be associated with sleep disturbances. When we track dysmenorrhea, which is the painful menstrual cramps, and the premenstrual syndrome, what's shown here is a menstrual distress score, which can be typical of what a woman would report who has these symptoms, where just before and around the time of menses, there is an increase in some of those symptoms, which can be physical as well as mood-related symptoms, and along with that, reports of insomnia and daytime sleepiness. So with the menstrual pain, there's a number of studies that have looked at the associations between menstrual pain and sleep, and they have found that across sleep satisfaction or measures of sleep duration and efficiency, women with dysmenorrhea report a poorer sleep quality and more insomnia symptoms during menses. That can often go along with a shorter sleep duration and a less efficient, so a poorer sleep that is being measured, and a greater daytime sleepiness the next day. The association between the severity of the menstrual cramps and the insomnia, there is an association as shown here, where the increasing number or increasing severity of insomnia is associated increasing severity of the menstrual cramps is associated with increasing severity of insomnia and a longer time to fall asleep, as well as more awakenings during the night. And some studies also show that it's not just during the time of menses when they're having menstrual pain that women have this increased risk for insomnia. It is women with severe menstrual pain overall having a higher risk of insomnia. The good news is that one of the most common treatments of menstrual pain, diclofenac potassium, a nonsteroidal anti-inflammatory, can restore objective and subjective sleep quality, as shown here, where women have, when they are being treated for their pain with a nonsteroidal anti-inflammatory drug, their sleep is restored to what it is at other times of the menstrual cycle, compared to if they were given a placebo. Now, if we look at women with severe PMS and premenstrual dysphoric disorder, this, what we see is that there is definitely a poorer sleep quality reporting and an increase in daytime sleepiness during the post-ovulatory luteal phase, especially near the time in the late phase. So this is near the time of menses compared to the follicular phase. So there's definitely women are aware of a poorer sleep quality. When we do measures from the polysomnography, we find some differences overall in their sleep, where the women with PMS have more of the deep slow wave sleep at both menstrual cycle phases. And that seems to relate to also changes that are found in their melatonin levels. So overall, looking at the menstrual associated disorders and sleep, there are analgesics that can relieve menstrual pain that can be effective in restoring the poor sleep quality that's evident in women with dysmenorrhea. The interesting thing with the dysmenorrhea is that sleep disturbances can contribute to central sensitization to that menstrual pain. So there's always this bidirectional effect from the menstrual cycle disorders and sleep. There's also limited work suggesting some disturbances in the sleep homeostasis and altered melatonin secretion in premenstrual dysphoric disorder, the most severe form of PMS, as well as some changes in rhythms like in cortisol and prolactin. There is some evidence, but there needs to be more work looking at chronotherapies such as light therapy and sleep restriction that can be influencing and improving symptoms in premenstrual dysphoric disorder. But definitely more clinical trials are needed for that. And I wanted to now, as a last point, just go back to the beginning, because it is really for women, it's important to consider their entire reproductive life cycle. And where do these influences of the menstrual cycle on sleep start before we talk about menopause, which is where they land up. And this analysis was done in a group of adolescents from a large study in the US, the Adolescent Brain and Cognitive Development Study, where we looked at young teenage girls and looked at the associations between sleep disturbances and menstrual problems and found that there was an association. So we asked them about the intensity of their menstrual pain and the impact of menstrual pain on activities. And you can see that the most severe is a score of 7 to 10, where about 20% were reporting very severe, intense menstrual pain. And on the right, you can see that the relationship between the sleep disturbance and the menstrual pain intensity is positive, so that the more intense menstrual pain, as well as the greater impact of menstrual pain on usual activities, was associated with a higher score of sleep disturbance. So even in these young teenagers, there is already an association between insomnia symptoms or sleep disturbance and menstrual pain. I just wanted to put the slide here to acknowledge such an important time period of pregnancy and postpartum in a woman's reproductive lifespan. It really is a topic all of its own because it is such a unique physiological and behavioral and psychological event. And it even postpartum as well, there is a whole lot of studies focusing on sleep during pregnancy and postpartum. And that is because it's women who, as they go through the trimesters of pregnancy, there is an increase in reports of sleep disturbances especially near the end of pregnancy. There is a decline in sleep efficiency. There is high daytime sleepiness in the first and the third trimesters in particular. And there's so many factors that are influencing sleep, going from the physical factors, the physiological changes. There's also the psychological stresses, as well as those hormone changes. And we also have to consider the presence of sleep disorders. So there is an increased risk for insomnia disorder. There's an increased risk for obstructive sleep apnea and restless leg syndrome during pregnancy. And the presence of these sleep disorders are risk factors for adverse health conditions and pregnancy outcomes, for example, gestational diabetes. So it's important to consider sleep in the context of pregnancy, and then once the baby is born, postpartum, to ensure that sleep is really given the importance it's due during pregnancy and postpartum. And another factor is that the way women sleep, the way they experience sleep, for example, postpartum, is also just another reproductive transition, as we see in the approach to menopause, where there is a further reproductive transition with those hormone changes, which is shown here, where we've got the reproductive years of the regular menstrual cycle cycling through. And then as you approach menopause transition, you've got those changes in hormones, along with a lot of increase in symptoms that can be influencing sleep. As well as what Dr. Andersen mentioned, there is a whole lot of psychosocial factors that are happening during these late 40s, early 50s, as women transition to post-menopause. And with that, I'll set that up for Dr. Maki to continue the discussion about sleep in menopause. Thank you very much.
Thank you so much. We've had Professor Andersen talking to us about sleep and introducing sleep to us. We're all very keen to know how much sleep we actually need. We just heard from Dr. Baker, who then introduced hormones to sleep. And now we wait to hear from Professor Pauline Maki, who is going to talk to us about menopause on sleep. Professor Maki.
Thank you. Can you all hear me?
Yes.
Wonderful. It's a pleasure to be here today with you all in celebration of World Menopause Day, and we made a month of it, didn't we? It's a pleasure to be here with Professor Andersen and Dr. Baker. Dr. Baker's done some of the most influential work in this area, so I'll be sharing some of her work. So we're going to move in now to the impact of menopause on sleep, why it matters, and how it happens. Our goals are to review evidence concerning changes in subjective sleep reports across the menopause transition and the factors that influence reported sleep, what your patients complain of. Then we're going to look into the science of this a bit and review evidence concerning changes in objective sleep measures. So here we're talking polysomnography and actigraphy across the menopause transition and the factors that influence that objective sleep. We'll characterize how vasomotor symptoms affect sleep. We'll describe the effects of sleep on cognition and mood. and we'll describe the effect of NK-targeted therapies for vasomotor symptoms on sleep. So let's move into the large studies that address the natural history of changes in reported sleep as women transition from the pre to the peri to the post-menopause. So this is the study of women's health across the nation. And again, here we're looking at the subjective sleep. We're going to be describing a lot of the data from this because this study is one of the largest, and it also allows us to compare subjective sleep and objective sleep. So for those of you who are unfamiliar with the SWAN, it's kind of the gold standard study of the natural history of menopause in women. This particular study on subjective sleep involved 3,045 women across various races and ethnicities. They were aged 42 to 52 and or pre or perimenopause at baseline. They came in annually and they followed them for 7 annual visits, which is what makes this such a rich database. Now, they did characterize sleep problems using an atypical, meaning it wasn't one like the Pittsburgh Sleep Quality Index. They had their own measure, which was the self-reported number of nights of difficulty falling asleep, staying asleep, and waking up earlier than expected during the previous 2 weeks. Here are the longitudinal data. So this is, if you will, the natural history and subjective reports of sleep problems. The first thing that you'll see is that there is an increase in all of these as women transition through the menopause from the pre to early peri to the late peri to the post, and that the most profound increases and the highest complaints are on the bottom one, so awakenings, with more than 40% of women in the late perimenopause reporting this. You also see that these changes emerge in the early perimenopause. The other thing that you'll clearly see is that for each of these 3 symptoms, it's the surgically menopausal women who report the worst complaints, particularly those not on hormone therapy. So this is a foundational study that contributes to our knowledge about when these changes occur and what aspects of sleep women report having the most difficulties with. A follow-up study examined, or follow-up analysis investigated what were the hormonal correlates of these longitudinal changes. And it was the decline in estradiol over time that was associated with trouble falling asleep, as well as with having more awakenings. In addition, for awakenings, again, the most troublesome, most common complaint, increasing levels of follicle stimulating hormone were associated with these longitudinal changes. Now, who reports the most sleep difficulty? Here, it's really important to recognize that surgically menopausal women who've had their ovaries removed and they've been thrown, if you will, into menopause, report the most sleep difficulty, consistent again with the idea that menopause does play an important role in sleep in women. Additionally, women with vasomotor symptoms, whether they're mild, characterized by having fewer than 6 days of hot flashes in the past 2 weeks, or if they're more moderate or severe or frequent, which is characterized by more than 6 days in the past 2 weeks, according to the definition of SWAN. These are the women that had the most complaints. There was a dose-response relationship between the frequency of vasomotor symptoms and trouble falling asleep, and that was true for wake after sleep onset as well and waking early. So the more hot flashes, the greater the subjective complaints here, where you get an odds ratio of 3-fold higher, for example, for waking up several times during the night among women who had reported hot flashes for 6 or more days in the prior 2 weeks. Now, let's go from the subjective reports to the objective polysomnography assessed sleep changes by menopause stage. And here we're going to the SWAN ancillary sleep study. This evaluated changes in sleep parameters among women who were initially pre or early perimenopause in relation to their menopause status at the second assessment. And they did combine pre and early perimenopause into one group here. So we had this nice introduction by Professor Andersen about polysomnography. Here are the data. So sleep duration and wakefulness after sleep onset did not vary by menopause stage across assessments. What they found instead is that women who transitioned to the postmenopause showed elevated beta EEG power in non-REM sleep. So what is this beta EEG power? It's an index of arousal. So the cortex is more active, if you will, than it should be at this point, but no change, interestingly, in the correlate of wakefulness that we saw it worsening of in the subjective reports. Importantly, that effect on arousal, cortical arousal, was independent of self-reported vasomotor symptoms. And so this idea is that the menopause transition is associated with physiological hyperarousal during sleep. Now, what factors contributed to aspects of objective sleep changes as women were in the SWAN? So here the design is a little bit different. Okay, so they examined hormonal factors prior to a one-time analysis of polysomnography assessed sleep. This was in a large sample of 365 women. And what they found is that the associations of sleep right now were stronger with longitudinal changes in follicle stimulating hormone prior to that point in time than to estradiol. So it was the changes in follicle stimulating hormone prior to the polysomnography assessment that were the most associated. So faster rates of change in FSH was associated with polysomnography assessed slow wave sleep and sleep duration, which was longer, even though many of those women were just at the beginning of the transition. They were pre or early perimenopausal. Greater FSH change was also associated with poorer sleep quality as reported subjectively by the women. In general, this study concluded that as FSH changes, particularly in this early phase of the menopause transition, women may be sleeping longer to compensate for poor sleep quality. So polysomnography is in the SWAN was done in a laboratory setting. There's now ambulatory polysomnography that can be done. A useful kind of bridge between the subjective and the objective assessments of sleep is actigraphy, as Dr. Baker showed. So this is a wearable device that you can wear at home in the comfort of your own home, but it provides more objective data, if you will, on sleep quality and aspects of sleep that we care about. So the SWAN examined age-related changes measured by actigraphy in 300 women at 3 different assessments. They were an average age of 52 at the first, 55 years at the second, and 64 at the third. Now, the focus of the study by Dr. Matthews was on age-related changes, and you have to dig into the supplementary material to really look at the menopause stage effects. But when you do see differences in different aspects of sleep when women are transitioning. So for example, sleep duration was worse in the late perimenopause, WASO was worse in the postmenopause, and sleep latency was worse in the late perimenopause and postmenopause. Now, I will caution here that the reference here is the combination of premenopause and early perimenopause. Those were put into one group. But you can see that the largest of these effects was on WASO, and that was, again, worse in the postmenopause. Now, what about aging? Sometimes when we hear about this menopause-related decrease in our sleep quality. We worry, is this the new normal? One of the broad conclusions from this study and from other studies in this area is that over time, sleep duration in WASO improves. So sleep actually improves in women, which is also a conclusion of the sleep cohort study from Wisconsin. So this was a probability sample of 589 women across 3 menopause stages. They were recruited from state employee records, and it was a polysomnography study that yielded some surprising data when it first came out. They used the SWAN definitions for menopause stage. And what they found, surprisingly, is that compared with menopausal women, postmenopausal women had significantly better sleep quality. This was evident in a 3.4% increase in the proportion of total sleep time spent in slow wave sleep, which is a good thing. They had 13.4 minutes of sleep overall and lower proportion of their time in bed spent awake. So this data challenged this assumption that in the postmenopause sleep worsens. Compared with premenopausal women, perimenopausal women had significantly less light sleep and more deep sleep, again, kind of challenging these assumptions. Somewhat surprisingly, they found that compared with menopausal women who reported no vasomotor symptoms, those who reported vasomotor symptoms had no differences in their polysomnography. And we'll show you later that this differs from what studies with actigraphy have shown. They did show a worsening of subjective sleep problems in different aspects. So it wasn't as though these individuals weren't complaining of sleep. It's just that they did not see them on the polysomnography. However, the greater complaints of sleep disturbance among women with hot flashes, that effect was not as robust in this cohort, as shown in the bottom graph. Okay, so what is associated with FSH? This is work from Dr. Baker, and I'm sure she can entertain more of your questions about this. But she also found notable associations between FSH and polysomnography related sleep in perimenopausal women. But this differed depending on whether the perimenopausal women had insomnia or if they didn't. Women without sleep complaints showed worse WASO and lower sleep efficiency with higher FSH. And that effect was independent of age, body mass index, and vasomotor symptoms. And she found something similar even in the premenopausal women. So this is early effects of FSH, again, kind of recapitulating some of the earlier data that we saw. However, in women with insomnia, it wasn't the hormonal factors that were associated with poor objective sleep. Instead, it was mood factors. So in my opinion, there remains a lack of knowledge on the longitudinal changes in objective sleep as women transition from pre to peri to post, because a lot of studies to date have really combined these stages together or have done cross-sectional work. So I think there's much more work we can do to try to understand these menopause-related changes in sleep, particularly since the SWAN study was started in 1996, almost 30 years ago, and the makeup of the population has changed around the world. Let's talk now about sleep disturbance and vasomotor symptoms. So vasomotor symptoms, hot flashes and night sweats being the characteristic hallmark symptom of menopause. For those of you in the sleep world who don't live in the menopause world, these are sudden intense sensations of heat in the upper body, particularly in the face, neck, and chest. They can last 1 to 5 minutes. In some women, it's followed by chills. Some women experience anxiety and heart palpitations. So when we think about hot flash associated awakenings, you can imagine that those symptoms can also contribute to awakenings. These symptoms are experienced by about 80% of perimenopausal women, but my hot flashes aren't your hot flashes. Women experience different types of frequencies and severities of hot flashes at a population level. They're the most frequent in the first 2 years of the post-menopause. The severity differs, and when we think about sleep, it makes most sense that Sleep would be disrupted perhaps by the moderate or severe hot flashes. So mild hot flashes, you feel the heat, but you don't sweat. Moderate, you sweat and you can continue your activity. Severe, you feel the heat and sweat, and you have to stop what you're doing because they're so severe. Things like breast cancer and surgical menopause are associated with worse moderate to severe. Another important thing to recognize is that contrary to popular belief for some time, we now understand that many women continue to experience hot flashes for many years after the final menstrual period. So even though the hormonal changes of the menopause can, if you will, resolve or reach a new normal, women can continue to have these vasomotor symptoms. And if they're untreated, they can contribute to some of the sleep disturbance. Now, what about hormone therapy, which is viewed as the gold standard treatment for sleep? Well, meta-analyses found that menopausal hormone therapy improves sleep only in women with vasomotor symptoms. Okay, so it's not, if you will, a panacea for sleep disturbance, but a very good option for women who do have vasomotor symptoms. Now, the way that vasomotor symptoms in sleep cluster differs. Again, this idea that there's no one menopause symptom. This is a cluster analysis of common menopause symptoms from the Ms. Flash studies. Just to orient you, they grouped women into different subcategories of menopause symptom experiences. 29%, the lucky few, had low symptoms. So not everybody experiences these symptoms at menopause. About 29% report few of them. Most women have predominantly moderate symptoms of sleep quality and insomnia, even though they describe having few hot flashes. Some women, 14%, have high levels of all of these symptoms. And so these women would be thought to have a very different experience of menopause compared to other women. So the way that sleep symptoms self-reported cluster with other menopause symptoms does vary among women. We showed that there's this dose response between the frequency of VMS in multiple aspects of sleep disturbance, something to keep in mind. Just as we measure sleep objectively, we can measure hot flashes objectively. Here's one of our readouts of a woman having 37 physiological hot flashes in 24 hours. This measures electrodermal activity accompanying sweating on the surface of the skin. On average, hot flashes last 7.4 years. But 33% of women have severe vasomotor symptoms, and vasomotor symptoms are prevalent in women aged 60 to 65 years. Okay, now objectively measured vasomotor symptoms have really been helpful scientifically in studies where sleep is also measured objectively. Here's a study by Rebecca Thurston that examined the minutes around a hot flash in terms of awakenings. And what she found is that these objectively assessed wake episodes were concurrent with 78% of objective hot flashes. In other words, if you use wearable devices to measure both symptoms, you see this close coupling between vasomotor symptoms and hot flashes. Dr. Baker found something similar in a study of perimenopausal women, where she found that about 69% that an awakening occurred within a 3-minute window of onset in 69% of nocturnal hot flashes. And again, this is in perimenopausal women. So readouts do show a close coupling. Not all studies show this, but there is a reliable association in some of the larger studies. This is one of my favorite illustrations. This is from Dr. Baker. And this shows you for the 34 participants in her research study, how many hot flashes they had. That's on the bottom here. And then at the top, the number of minutes they spent awake when they wanted to be sleeping. And then how many of those wakes were associated with hot flashes. So you can see that there are wake episodes that are not associated with hot flashes and others that are. And hot flash associated wake time was responsible for, on average, 27% of objective Okay, so of all the time spent asleep, 27% of that was associated with a hot flash. So something else it seems to be going on in this study. Experimental manipulations of ovarian steroid hormones have led to insights into sleep. This is an objective measure of sleep efficiency in medically induced menopause, so a GnRH analog. So if you experimentally induce menopause, what happens? Well, it depends on the hot flashes. And women with hot flashes, after you've done this induction of hormonal suppression with the GnRH analog, those who have the hot flashes do in fact show worse sleep efficiency, whereas those without hot flashes do not. About 20% who did not have the hot flashes following that intervention. The effect of nighttime vasomotor symptoms on polysomnography measured sleep disturbance in this medically induced menopause paradigm led to some pretty interesting results. If we focus on the right, it's interesting because you can quantify the effect of each nighttime vasomotor symptom. So each nighttime vasomotor symptom was associated with a 62% increase from baseline in polysomnography measured wakefulness, 3% increase in awakenings, and a 6% increase in N1 sleep stage. So again, in this model, evidence of a close coupling between vasomotor symptoms and sleep disturbance. And this led to mood disturbance. So healthy premenopausal women in that study who did develop those nighttime vasomotor symptoms after that GnRH analog, they showed worse mood. So this carryover effect, if you will, to mood for having this menopause-related sleep disturbance. Okay, now among healthy premenopausal women who were treated with that GnRH analog, that disturbed sleep leading to disturbed mood held even after you accounted for increases in nighttime vasomotor symptoms. So those declines in mood following this experimental model, that was the greatest among women who also showed an increase in objective measures of sleep disturbance. And this was independent of nighttime hot flashes, saying that sleep disturbance here, its association with mood, doesn't necessarily seem to be tied to the nighttime hot flashes. So both sleep and nighttime hot flashes contribute to this worsened mood. Now, what about cognition? This is the world I live in. We did a densely sampled study studying women's cognitive performance. 85 women sampled every 6 months, over 400 longitudinal visits. And we found that there was a subcluster of women who did experience cognitive problems, primarily in memory. And what differentiated that cluster of women from other women was sleep disturbance. So evidence of sleep disturbance affecting cognition in the perimenopause. Here's some data from our study, Ms. Brain, showing that sleep inefficiency is measured by actigraphy, is associated with alterations in memory circuitry as women are performing tasks. The greater the sleep inefficiency, the more her brain circuits, her memory circuits have to work to do what they need to do to sustain memory. And this particular measure, if there's any neuroimagers, is a measure of hippocampal functional connectivity. There's also a need for a balance between your daytime activity and your nighttime rest. So we talk a lot about sleep and its impacts on cognition, which of course are robust. The field of Alzheimer's disease is moving into this idea of rest activity rhythm. So this rhythm between the desire to be more active during the day and more restful at night is shown by this upper graph. So that's a rest wake activity rhythm. The more robust that is, the more you get this differential activity between day and night. And that's thought to be a really healthy thing. We recently published data showing that the more you have that robust wake activity, difference, the better your processing speed. And interestingly, the more robust that rhythm, the lower blood levels of Alzheimer's disease biomarkers. We know there's a close coupling between sleep and Alzheimer's disease biomarkers. In this analysis, we showed that the association between rest-wake activity was independent of the association of sleep with those. So sleep matters, rest-wake activity matters for cognition and for Alzheimer's disease biomarkers in this cross-sectional study. And then finally, we had some data showing that wakefulness is measured by actigraphy was associated with alterations in brain structure, specifically more ischemic lesions, these small stroke-like lesions in the brain. The greater the wakefulness after sleep onset, the more these stroke-like lesions. We don't know if this is causal, this is an association, but it is in line with studies where you can see alterations in cognitive function and brain function when you induce sleep deprivation. So what about our final item, which is, are we learning anything more about why women experience these sleep changes as they transition through the menopause? And here it's helpful to talk about what we might be looking at in the future, and that is these neurokinin targeted therapies for vasomotor symptoms. So candy neurons in the infundibular nucleus of the hypothalamus are now known to play a key role in the generation of hot flashes. Those neurons, those candy neurons, project to heat dissipation effectors that affect our experience of vasomotor symptoms. These neurons become overactive in the menopause because of estrogen withdrawal. Estrogen typically puts the brakes on those neurons. So when menopause comes and estrogen is lost, then those neurons go into overdrive. Those neurons express a receptor for neurokinin B. And if you antagonize that receptor with a neurokinin targeted therapy, hot flashes are relieved. Now, what's interesting for a sleep perspective is that those candy neurons in the infundibular nucleus also express NK1 receptors, and NK1 receptors have a ligand, substance P, and substance P is thought to play a role in sleep. So it's interesting that these new targeted therapies in clinical trials, randomized trials, really show some reliable effects on sleep. These NK3 receptor antagonists, fezolinetant, it's a single receptor antagonist that's shown efficacy in improving sleep in their randomized trials. Skylight 2 did not show that benefit, but the other studies did. Elinzanetant it antagonizes not only NK3, but also NK1, and that's shown reliable, reproducible benefits to sleep, even in women, interestingly, with no minimal vasomotor symptoms. So you didn't have to have a certain threshold of vasomotor symptoms to be in that. You just had to be bothered by that. And then also, interestingly, in women with breast cancer. So this raises the desire to understand more about NK1 receptor antagonists and their role in sleep, and raises hypotheses that perhaps, although it's not yet known, NK1 may play an important role in menopause sleep disturbance. So this might happen because substance P, the ligand for NK1, has been shown to play a role in regulating sleep-wake cycles. Substance P is active in the hypothalamus. It co-localizes with other neurotransmitters that are known to play a role in sleep. And further work is needed to characterize this. So in summary, for subjective sleep, reports of sleep difficulty increase beginning in the early perimenopause and persist into the postmenopause, with wakefulness after sleep onset being the most frequent complaint. For objective sleep, particularly polysomnography, findings are less reliable. In studies examining objective sleep parameters longitudinally from pre to peri to postmenopause are really, in my view, lacking because of the combining of those two first stages together in some studies. Evidence does suggest that objective sleep parameters improve in the late postmenopause. We know that vasomotor symptoms play an important role in this, but most wakefulness after sleep onset, shown beautifully by Dr. Baker's study, is unrelated to vasomotor symptoms. So they play a role, but it doesn't explain it all. Sleep, mood, and cognitive disturbances commonly co-occur, especially with vasomotor symptoms. We have to think about sleep as part of a cluster of menopause symptoms, and the role of NK receptors in sleep disturbance is yet to be elucidated. Thank you for your attention, and I think we'll now go into the Q&A.
Well, thank you, the three speakers, for the very nice introduction and comprehensive data in the field. It was very nice. And we have several questions from the audience. And I will start with number one to Dr. Andersen. Is non-REM sleep more important than REM sleep?
Wow, very intriguing question. I would say that sleep should be considered as adequate. We have to join non-REM sleep and REM sleep. Missing REM sleep, we lose the colorful of life. I used to say when I'm giving talks here to the students that REM sleep give us the well-being, give us the most joyful part of the night. So we must have the amount of hours of sleep to each of us, but we have to combine both of them. We cannot just forget the REM sleep. Thank you, Dr. Poyares.
Well, let's move to the next one. How much sleep is, this is tricky question. How much sleep is sufficient for a 65-year-old postmenopausal female?
Wow.
Yeah, with insulin-dependent, well-controlled diabetes. She's asking because her mom is sleeping 4 hours per night.
How many hours per night?
4, just 4.
Okay, I think the first thing is to control the comorbidities. With that situations are controlled, we can think now about the sleep. When you have medication and we have some pathological conditions, we must control that first. I would say it's not the minimum amount, but we really need to have the adequate balance between REM sleep and non-REM sleep. With 65, I would say 4 hours, I think, is not enough. But you have to talk to the clinician to first control the glycemia and everything. For then we talk to a sleep specialist to kind of recover some few hours more than just 4 per night.
Any comments from Dr. Baker or Dr. Maki?
I agree with Dr. Andersen that you have to know, I think it's always important if somebody is noticing that they're having trouble with their sleep, any problems with their sleep and feeling sleepy during the day, then then they do need to bring that up. Sometimes I think there's not much time when you speak with your healthcare provider, and if you don't bring up sleep, the healthcare provider is so busy, they might not ask about your sleep. So do mention it, do ask about it. Sleep is important, as we showing for everybody. It's important to get it right. So there can be so many factors that influence it as well, though. So I agree with Dr. Andersen. Got to treat the comorbidities.
So, next question. How being on menopause and being neurodivergent affects sleep, even when taking hormone replacement therapy and being balanced? I don't know exactly what balanced is, but this is the question on if the combination of menopause and neurological conditions, whether these have any potential additive effect on sleep. I think
Dr. Baker, I don't think we have research on neurodivergent individuals and their sleep, but I'll tell you generally, remember I described that meta-analysis that said that hormone therapy helps sleep in women with hot flashes, but doesn't otherwise help sleep. It's not as though sleep normalizes necessarily if you're adequately treating your VMS. And you saw beautifully in Dr. Baker's study how the majority of time that we're awake when we want to be sleeping is not related to vasomotor symptoms. So very often women need other approaches. We recommend cognitive behavioral therapy, of course, for insomnia is a really powerful approach. CBT coach is available through the VA. So I don't know, Dr. Baker, do you want to say anything further?
Well, I think that I suppose we don't know the context for that person's specific question, but I think maybe more broadly, there's also some other questions there about the use of hormones and treating sleep problems, whether it's the hormone therapy. Also, there's some questions about progesterone alone and testosterone. I think that the reason I was so happy to participate in this webinar as well is to help raise awareness that there's so many questions that we don't fully understand, especially when it comes to some details like, will this one hormone help sleep or does it worsen sleep? What are the differences between individuals? Because there's also, I think like Dr. Maki said, there's not everyone is the same. So one person's hot flashes are not the same as another. One person's sleep is not the same as another. And our full understanding, as you also saw with Dr. Maki's presentation, about the links between the hormone changes that are our natural hormones going on inside our bodies as they change, are very complicated and react with sleep in different ways. And then if you also look at hormone replacement or hormone treatment, that is also complex. So just to quickly summarize, I suppose there is some evidence progesterone can lead to an increase in sleepiness. So if it's being used as treatment, it's often recommended to take it at nighttime. But it doesn't cause sleepiness in everyone. It does depend on the source of, if it's say intrauterine, it's less likely to have an effect. And then the hormone therapy again has it's a consideration for women. It's just one choice, and we have a growing number of options for women.
Yeah, I might add that there is not support for testosterone as an intervention for sleep. And with progesterone, randomized trials have gone up to a dose of 300 milligrams. And surprisingly, it didn't have carryover effects to mood. So a lot of women find benefit from that, but others don't respond at all to it.
Thank you. And we move to the next question. And it's a very interesting question. It's addressed to Dr. Baker. What do you know about how the use of contraceptives, oral contraceptives, in general, affect menstrual cycles relative to sleep?
So that's a great question. Actually, our colleagues at Sao Paulo have done a lot of work looking at that. And I think, again, I don't want to always make it sound like everything's complicated, but it is, because the oral contraceptives, there's also different formulations, different levels of the hormones. But we did a study. This was a study I did in my lab in South Africa a number of years ago, and we did find that a combined progestin estrogen oral contraceptive affected the polysomnographic measures of sleep. So increased the type of stage 2 sleep, and then others have shown an increase in spindle activity. So that can relate to those progestins having an effect, just like the natural hormones do. But overall, when you look at the sleep quality and insomnia symptoms, meta-analyses show that women taking oral contraceptives have a lower risk of insomnia compared to women who are not using oral contraceptives. But again, it does does come down to the formulation that someone might be using.
Thank you. There are many more questions. And does vaginal progesterone have an effect on the sleep? Does it affect the sleep?
I think the levels systemically are too low to suggest that it would affect sleep.
So there is this question about men taking progesterones to sleep, and I know that there have been some men in who take progesterones when they're on flight to help them sleep. Any comments on that? Just to keep this as a light banter.
So this can we link to the next question? What's the impact of progesterone and testosterone on sleep? I don't know if this is the reality in many countries, but in our country there are some implanted chips that they deliver progesterone, estrogens, and also testosterone. And this is becoming popular in in some countries. So could you comment on the effect of this hormone replacement in sleep? I think the question is more about the combination.
Well, I would just start by saying that sleep, it really, when we're talking about sleep and what type of sleep problem someone might have, does depend on how you might consider treating it. So if someone has sleep disturbances, trouble sleeping, insomnia, the first line of treatment is not to go with a hormone treatment. It's to treat their sleep problem. And actually the gold standard treatment for insomnia is cognitive behavioral therapy for insomnia, where it really helps to do all those extent of what Dr. Andersen had showed with like giving relaxation therapy, also making sure the bedroom, just changing the cognitive thoughts around sleep, and a lot of behavioral work to improve sleep. So that's really the gold standard treatment for sleep problems. And I think Dr. Maki can also talk about, say, in the context of menopause, with if it's vasomotor symptoms or the combination.
I think there's a bigger role for CBTI than we could ever realize, and too much emphasis on the hormonal contributors. Because the other thing that happens when women go through menopause is they wake up and they ruminate. So the behaviors that they engage in when they have a hot flash associated awakening can, continue that wakefulness time, even if she's on a treatment for her hot flashes. So it's a very complex dynamic here, and all the hormone therapy in the world is going to help you to stop ruminating when you wake up.
There is this question here about, does sleeping in early hours of night is better than late night sleep? Does it really matter?
Dr. Andersen, you can.
Okay. I would say that the first 4 hours of sleep we call essential sleep. So we have a little bit of each phase of sleep. But again, each person has their minimum amount. So we cannot just say we have to sleep between 7 and 8. This is majority of people, but we have to at least have the 4 hours of sleep plus the additional that is from each one. Tell anyone that the first few hours is the most important, I will disagree. I think we have each one have the complete amount and the quality of sleep. And if we talk about menopause, a woman could easily sleep maybe 6 hours and not feel refreshed. So she might have a lot of the amount that she need, but not the complete quality that each phase confers to their sleep. So I would say that is much more between quantity and quality, especially in menopause, that we could just say few hours is not enough.
Thank you. I think we're coming to the end of it. If I might just summarize, when it comes to sleep and women, And we're trying to help sleep, especially when someone is going through the menopausal transition. I think we need to look at all the changes that she can do to herself, cutting down the coffee, cutting down the blue light, and trying to get her bedroom into a perfect scenario to sleep. We also talked about cognitive behavioral therapy. We talked about estrogen, progesterones in whichever way, oral and vaginal. Can I have just the last few, if all the three speakers could just, just say a few words to end this session? Can we start with Professor Monica Andersen, please?
Thank you very much for this opportunity. And as a take-home message, I would say that more studies should focus and not forget about cultural factors. That we are so complex when we talk about women, but we also have to consider different realities and diversity that we have across science in sleep in women. And thank you very much again for this invitation.
Thank you. Dr. Baker?
Well, thank you so much. It's been such a pleasure taking part in this discussion. And I think I would just reiterate to women not to forget about sleep. Sleep is so important across the entire lifespan. And yes, it cycles through differently. For some women, it might be with the menstrual cycle, it might be postpartum, it might be around the time of menopause. That their sleep could be disturbed. And it's important to acknowledge that, to know that there's many people who are experiencing sleep problems and to speak about it. There is a growing number of awareness. There's a growing awareness and a number of options that you can look for that can help you have a better night's sleep.
Thank you. Pauline?
I would say that it's World Menopause Week. The International Menopause Society has a beautiful set of materials on lifestyle medicine for menopause. I think it's timely because I think we're hearing too much about, oh, take this hormone pill and it will improve everything under the sun. That's not what menopause is about. Menopause is much more complex than that, and that's true for sleep too. Much we can do to improve our sleep that has nothing to do with hormones. And I encourage all of you to read that while appropriately treating vasomotor symptoms for your.
Thank you so much, Pauline. And I'd like to thank my co-moderator, Professor Dalva Poyeres, who helped me with this particular session. If I could share the last few slides. Please visit the IMS website to find out more about the many educational events and resources that you see listed here and about becoming an IMS member. Many resources are available for free, including the exclusive offers for IMS members, free 1-year IMS membership with completion of Impart Level 1, IMS membership offers in partnership with local regional societies who are members of the Council of Associated Menopause Societies, CAMS. There are monthly live events and extensive library of educational resources, and you can find all this out more from www.imssociety.org. And the most exciting thing to happen for IMS in 2026 is the 20th World Congress on Menopause at Rio de Janeiro between 30th of September to 3rd of October 2026. You can visit the Congress website to get more information. Thank you very much, ladies and gentlemen. We've had a very exciting sleep session today. And as Pauline and I had said, this is all part of restorative sleep, which is part of lifestyle medicine, which is the theme for World Menopause Day 2025. Thank you. Good morning, good afternoon, and good day to all of you.
Thank you.
Thank you.
Bye.